Hello and welcome again to the Certificate of Professional Practice in the Epidemiology and Control of Non-Communicable Diseases. This is lecture number 7 entitled NCD Surveillance in Public Health. So to begin with, and as always, I want to take a moment to thank those who've made the lecture series possible, especially the Pacific Island Health Officers Association, the University of Arizona Zuckerman College of Public Health, and the College of Micronesia Public Health Training Program. And without the backing of these institutions, and these lectures could not be provided. And of course, and you've heard me say this multiple times, and I'm going to say it again anyway, I want to thank you, the participant, because it's your dedication in improving yourself, no matter where you are across the Pacific, that makes me motivated to put these lectures together. Okay, and I also want to mention the United States Centers for Disease Control and Prevention, from whom these lectures have been adapted, and I do want to let you know that the opinions I express herein are my own and do not necessarily represent those of the CDC, PHOA, or COM-FSM. So thus far in this lecture series, we've talked about a brief introduction to what epidemiology is and its importance to non-communicable diseases. We've reviewed the burden of NCDs in the Pacific with an emphasis on related risk factors and the need for risk factor surveillance. We've covered the burden of disease, including basic epidemiological measures such as incidence, prevalence, disability-adjusted life years, and so forth. We've talked about the different types of descriptive and analytical studies. We've discussed how to analyze and interpret surveillance using primarily descriptive epidemiology, and most recently we talked about how to prioritize public health problems in an environment of limited resources, and those are all of the environments in which we work here in the Pacific. So in this lecture, we will discuss the use of surveillance systems in NCD epidemiology. Now, as we've been stressing across all of these lectures, public health must be evidence-based in order for us to make the best possible decisions. Epidemiology is the science behind gathering this evidence and then analyzing it, and surveillance is one of the methods by which we gather this information. So to begin with, we will talk about the role of surveillance in NCD epidemiology. And as I mentioned, surveillance data are data for action. Now, data is collected so that they can be used to implement changes. This presentation will begin by reviewing the basics of surveillance, including its definition and purpose, and then we'll move on and we'll talk about NCD surveillance, and we'll actually give some specific examples, one of which you will be well aware of in most of your jurisdictions, and that's going to be the WHO STEP survey. So what is surveillance? And more importantly, what is the purpose of surveillance? So here we see the WHO definition of surveillance, and it is systematic ongoing collection, collation, and analysis of data and the timely dissemination of information to those who need to know so that action can be taken. So first of all, it is systematic, meaning that there are policies and procedures in place to collect the data. Second, it's ongoing, meaning that this is something we routinely do to collect data on specific health conditions in the population. Now, this is very important as we need ongoing data from which to make decisions. If we only have periodic data, then it becomes very difficult to make comparisons between years and also comparisons between different portions of the population. And of course, the final purpose of surveillance is to create some form of action. In other words, we're learning something about the target population so that we can take action to correct that. For example, if we learn that a high rate of adolescents are using tobacco through systematic surveillance of risk factors, then we can develop programs to help prevent adolescents from beginning to smoke and help those who are already using tobacco to stop using it. So surveillance can provide different types of information. And this can include both epidemiological as well as clinical information. So here are several examples of how this occurs. So by collecting surveillance data, we can establish baseline rates of disease, which will allow us to determine if there's been an increase or a decrease in the disease in the population we serve. You may recall that we use the terms endemic and epidemic to describe this relationship. Now, surveillance can also help public health officers and clinicians estimate the extent of a public health problem in the population, as well as determine where the problem is based upon geographic distribution. It can also be used to understand the natural history of the disease, including risk factors, when symptoms first present, how the disease progresses, and ultimately what interventions are effective and what interventions are not effective. And finally, it can be used to generate hypotheses about what is causing a health condition in the population. Now, surveillance not only is useful in the collection of epidemiological and clinical information, but it can also be used to inform public health efforts. So this is what we refer to as evidence-based public health, or interventions that are developed based upon good information on the extent of a health problem in the population. This can then be used to monitor rates of chronic disease such as cancer and hypertension to determine whether interventions are effective in lowering rates. It can also be used to facilitate future planning. So for example, if we know that large numbers of adolescents are smoking, and we know that this will most likely continue into adulthood, then we can begin to plan for a large patient population that will suffer from asthma, COPD, lung cancer, and so forth at some point in the future. So here we see some examples of the types of information that can be collected with public health surveillance systems. So the data collected from NCDs can be based on diagnoses, and those can come from physicians and other healthcare providers, but it can also entail collection of information about conditions as well as those important lifestyle risk factors that we've talked quite a bit about. Now recall that this is once again one of the take-home messages from this lecture series, or that with NCDs we are concerned about risk factor surveillance as opposed to strictly disease surveillance. Now, there are some similarities between NCD surveillance systems and infectious disease surveillance systems. Both provide prevalence data on disease rates. Both can document risk factors for diseases. Both can be used to describe changes in disease rates over time, such as months or even years. And both can include laboratory data, self-reported data, such as surveys, and medical records data looking for diagnoses, risk factors, and so forth. But whereas infectious disease surveillance is most concerned with identifying outbreaks of communicable disease, in which action must be taken to stop the spread of the disease, NCD surveillance is primarily concerned with risk factor surveillance to identify populations at risk for developing NCDs in the future. Now, there are several obstacles to NCD surveillance. The primary one is lack of resources or infrastructure. This can include limited or no collection mechanisms being in place, or in other words, the total lack of a surveillance system, including personnel, policies, procedures, and so forth. And this actually might be the case where you work. It might be that there simply is not a well-developed surveillance system already in place. And I've seen that in different places throughout the Pacific. And it's not a reflection upon the desire of the public health system to do good work. It simply is they may not have the resources to put such a surveillance system into place. Or it might be that there's a limited transmission capacity. So in other words, how does surveillance data gathered at a remote site get transmitted to the central public health facility? Now, I worked once in a South Pacific island on a dengue outbreak, which was spread across over 50 very remote islands. There was limited surveillance capacity, and where it did exist, there was an issue of getting the information to the main island. We couldn't use landlines because they didn't exist. We couldn't use mobile phones because there was no cell network. We couldn't use the internet because there was no internet network. So oftentimes what we had to rely upon was high-frequency radios that didn't always work. Or, worst case scenario, we had to wait for someone to bring the data over long distances to the central public health facility when they traveled there. Now, there is also the issue of NCD surveillance being a low priority politically, and that does happen sometimes. But I must admit that I'm very proud of us here in the Pacific because we've actually made NCDs quite a high priority, and so that isn't always going to be a problem for us. Now, getting the funding, that might be a different issue. And finally, there's also the issue of unenthusiastic participants. Now, this can be a significant problem. Now, often we're asking physicians and nurses and other busy clinicians to collect the data for us from their patient encounters. Now, to the physician or the nurse, oftentimes this seems like one more piece of paperwork that needs to be completed in an already busy and overworked schedule, and who can blame them in that situation? So oftentimes the routine surveillance doesn't happen simply because healthcare workers are overworked and they may not make it a priority to collect and report the data. So we'll now talk about the structure and function of surveillance systems, and this is going to include population, data collection, data compilation, and finally analysis and dissemination of results that are drawn from the data. So what are the components of a surveillance system? Well, the first component is the population under surveillance. Now, different surveillance systems conduct surveillance among populations with different characteristics. But there are generally going to be national surveillance systems in place in many countries that are intended to capture the health status among the population of an entire country. Then there is specific surveillance of high-risk groups, which may be found only in specific areas of the country or in specific occupations or specifically at-risk groups. Now, this includes people who work in high-risk occupations, those with a specific health status, such as tuberculosis or HIV, and finally those living in a specific area, such as the Marshall Islands, where we had high rates of cancer associated with the nuclear testing in the 1950s, well, really in the 1940s and the 1950s. Okay, so it really depends upon the target of the population. But obviously, once you define the type of information that you want to get, then the target population becomes readily clear, and you can begin working on identifying that population. Now, in addition to the audience, the next component of a surveillance system is the data collection process itself. Now, data is collected about the health status of the defined population. This collection is generally undertaken at the local level, such as at a state or district health office. So, for example, in the Federated States of Micronesia, this would be each of the 4 state health departments and then the specific programs within these health departments, such as cancer, tobacco, diabetes, tuberculosis, and so forth. Those departments which collect data should use standardized methods so that the same type of data is consistently and correctly gathered. These systems can be electronic, or more oftentimes than not, here in the Pacific, because we're doing the best job that we can, they'll be paper-based collection systems. Okay. Now, for some NCD surveillance efforts, there may be laboratory data collected as well. So, for example, with diabetes, we would have diabetes lab tests used to document glucose levels, and that could be used as a form of surveillance data as well. So along the lines of gathering data, we do have this issue of data that already exists, or existing data, okay? Now, if collecting new data is not feasible due to issues such as cost or lack of personnel and so forth, you can use already existing data that has been collected by other organizations who might keep health-related information. Now, this could include hospital records or health service management systems, just as examples. Now, it's important to note that the collection of data is expensive, both in terms of money and personnel and time. So new data should only be collected if existing data cannot fill the current need. So in other words, only if there isn't an existing set of data that can answer the research questions that you're looking at. Now, one way to use existing data, as we already mentioned, is to use hospital records. And if these come in electronic format, then they can be particularly easy to use. But it might come in the form of registries and patient charts and things like that. Another source in countries with very highly developed vital record keeping systems would be the vital registries, such as the births and the deaths. And these can be used to conduct surveillance of major causes of disease within the population. Now, of course, it should be noted that death data is highly dependent upon the physician or other healthcare provider who completes the death certificate. If the data on the cause of death is highly generic, such as saying somebody died of cardiopulmonary arrest, which everybody eventually dies from, it simply means the heart stopped and the lungs stopped, okay, then this is of little help in determining the major causes of mortality in a population. So, from the standpoint of surveillance, once again, if you've got good data going into the surveillance system, then you can get good analysis and good decision making coming out. But it's important that you get good data actually going in. Now, it's important to remember that surveillance is more than just data collection. And for those of you who have completed the DDM course, the Data and Decision Making course, you are well aware of the data collection cycle. We talked about that quite a bit in that program. So do keep in mind that surveillance is a full cycle that involves completely processing, analyzing, interpreting, and then using the information before once again repeating the cycle to collect new data. Now, I want to stress that data analysis, interpretation, and dissemination must be done in a timely fashion. If data is collected but not analyzed for months and sometimes even for years, then the results of the analysis will be out of date and they'll be of little value for making appropriate decisions. Now, I would caution you that it is not advisable to collect data if you do not have the means to analyze, interpret, and disseminate the results. Such a situation really is a poor use of resources that will not result in any actual change in the target population. There's also the question of whether you can do anything about the problem in the population once you've collected and analyzed the data. Now, of course, ultimately, it's better to identify gaps in the knowledge so that plans can be made to address these issues at a future date. But do keep in mind these issues in terms of collecting data if you don't have the ability to analyze it, and even if you do have the ability to analyze it, do you have the resources to develop an intervention in that population? They're tricky ethical, really, questions that need to be answered here. Now, another key element of surveillance system is stakeholder involvement. Now, stakeholders play a key role in assuring that a surveillance system functions at all levels. Now, as you can see, stakeholders can come from a variety of backgrounds, including those who use the system, such as public health officers, healthcare providers who are part of the input of data into the system, as well as various governmental and non-governmental agencies that will make use of the data. The important thing is to remember to include those stakeholders which are relevant to your system in the implementation and evaluation of that surveillance system. So, for example, recall earlier that I mentioned physicians are a source of surveillance data, but that their input may be limited by the number of patients that they see and their feeling that they already perform enough paperwork. Physicians are stakeholders and very important ones. So if they are involved in the design and implementation of a surveillance system, they may be more willing to routinely participate and hence increase the efficacy of the surveillance system itself. So now that we've talked about the role of public health surveillance and various components of the surveillance system, we can talk about operational aspects of surveillance systems. This will include actual sources for data and types of data that is used. So here we see a list of priority sources from which we can get data for NCD surveillance. Now, this is only a partial list, and many other sources of data may exist in your own home country or jurisdiction. Now, while this provides you a generic overview of sources, such as disease registries, we will not discuss these in depth today. Rather, in Lecture 8, which will be presented next month, we will discuss sources of NCD surveillance data. But what I would like you to do is take a moment and consider what are the sources for surveillance data that are routinely available in my country. Now, in general, we can categorize the methods of collecting data for surveillance into two main types: passive surveillance systems, and active surveillance systems, okay? Now, there are many ways of structuring a given surveillance system, whether it's active or passive, but the general types of surveillance systems can include population-based surveillance systems, and those can be either active or passive, and sentinel surveillance systems, once again, which are primarily going to be either active or passive. Now, over the next few slides, we'll talk about methods of data collection and the structures of these two types of systems. Now, passive surveillance is the most common type of surveillance. Now, examples would include health management information data as well as hospital and clinical records. Now, we say it's passive in the sense that it waits for others to report the information into the public health agency, and that the health authorities take no action while waiting for the information to be submitted to them. So in other words, it is passive on the part of the public health system while they wait for clinics and disease registries and others who collect data to simply report that data to the public health agency. Now, one of the reasons passive surveillance is so popular is that it is inexpensive to use and requires very little in terms of personnel. Rather, the personnel are provided by the clinics and the hospitals, as well as the different agencies where the data is collected as part of their routine duties before being forwarded on to the public health agency. Now, some disadvantages include delay in reporting because those responsible for the data collection, such as nurses and others, have other duties to perform, as well as missing or incomplete data when the data is actually reported to the public health system. Now, active surveillance requires action on the part of the public health officer to actually collect the data. So examples would include site visits to collect data, telephone surveys, going door to door, handing out surveys, and things like that. The important thing is to remember that this requires action on the part of the public health agency. They are not waiting for data to be provided, but are actively going out and collecting the data. Now, active surveillance systems require more effort and personnel and thus are more expensive to operate. However, such systems result in more timely and complete collection of data. Examples might include annual surveys that look at lifestyle risk factors, such as the Behavioral Risk Factor Surveillance System, or even the WHO STEP survey. So we'll now transition from data collection methods to talking about the different general structures that a surveillance system might have. Now, a population-based surveillance system, as the name suggests, accepts data from all providers and all laboratories and all other sources in the country. Now, often there is a legal mandate to collect this data. So examples of this would be the mandatorily reportable disease list that most countries maintain, in which physicians, labs, and other providers are required to report such diseases when they are encountered. Now, in a population-based system, there is local collection, which is then passed to subsequently higher levels. So, for example, within the Federated States of Micronesia, the cancer program may collect data which is then forwarded to the relevant state health department. This, in turn, is forwarded to the national government level, and from there may even be reported to CDC, WHO, and other agencies as well. Sentinel surveillance is usually conducted as a part of a population-based surveillance system. Now, this involves surveillance of a specific subset of the population from a limited number of sites. So, for example, you may have a Sentinel surveillance site that includes a percentage of all the health clinics in your specific country or jurisdiction. A Sentinel system can be active or it can be passive. By selecting only a few sites, but sites which are geographically representative of the larger population, you can have a better sense of what is occurring in the larger population. So, for example, if there are 10 clinics on your island, then having surveillance in all 10 clinics would be expensive and difficult to do. However, if 3 of those clinics from different areas of the island are collecting data, then it would be representative of all 10 sites and give you some form of early warning about disease outbreaks if it was an infectious disease surveillance sentinel system, or from the standpoint of NCDs, it would give you information on lifestyle risk factors as well as the diagnosis rates of various NCDs. So Sentinel systems are smaller and they are more flexible and therefore are useful for establishing surveillance if there is no existing surveillance system in place. It is also useful for a specific disease, such as influenza-like illness, or if a system has been disrupted because of a natural disaster or other event, a Sentinel surveillance can help you reestablish your surveillance efforts in your country. Now, although Sentinel surveillance systems can be expensive, they're less expensive than data gained through active surveillance of the entire population. Let me just say that one more time. Although Sentinel surveillance systems can be expensive, they are less expensive than data gained through active surveillance of the entire population. Furthermore, the data collected is generally of higher quality. Now, one disadvantage of Sentinel systems is that it is difficult to ensure that the sites are representative of the larger population. And like we said, it is expensive to establish and maintain a Sentinel network, especially compared to the traditional passive surveillance networks. All right, now that we've talked about active versus passive and population-based surveillance, including Sentinel site surveillance as a form of population-based surveillance, we'll now talk about disseminating information from surveillance systems. Now, it's important that once data is collected and analyzed, that it is disseminated to those who will make decisions based upon the data. Once again, data is for action. You must always consider who are the groups of people to whom my data should be dispersed. This might include decision makers in your organization, healthcare providers, as well as the population that we're conducting the surveillance on through various forms of health education. Now, this is only a partial list, and I'm sure you can think of lots of others in your particular jurisdictions. So now let's look at an example of NCD surveillance system in action. And I'm sure many of you are aware of the WHO STEP survey, which we're going to discuss briefly on the next slide. Now, the WHO STEP survey provides an entry point for middle and low income nations, such as those of us here in the Pacific, to get started on NCD surveillance methods. And I know quite a few of the jurisdictions across the US API have already done the WHO STEP survey. Now, the WHO STEP survey is also designed to help countries build and strengthen their capacity to conduct NCD surveillance. Now, the goal is that the STEP survey is repeated every 3 to 5 years, because remember, one of our goals of surveillance is it's ongoing and systematic. So, once, like I said, the goal is to repeat it every 3 to 5 years to provide ongoing data collection. Okay. However, this may be difficult for some countries. All right, we may lack the resources, or we may the financial resources or the personnel to go out and do the actual survey, or we may actually lack the resources to undertake the statistical analysis as well. Okay, so it's important to keep that in mind, that the time frame between STEP surveys might be longer depending upon the resources you have. Now, as many of you probably know, there are 3 steps in the STEP survey. First, a questionnaire is given on lifestyle risk factors as well as demographics such as age, gender, ethnicity, all that wonderful stuff, okay? And then that's followed by physical measurement as well as biochemical measurements in terms of NCD risk factors. Wow, look at that. We only took about 22, 23 minutes today. I'm really excited. So once again, you've made it through, and congratulations. So as always, I do hope that you've learned something today. And as always, I do want to thank our sponsors that I mentioned at the beginning for supporting these lectures. And most of all, I want to thank you for your hard work and dedication. Like I say at the end of every lecture, I know how busy you are, and I'm so thrilled that you've taken time away to improve yourself in regards to epidemiology. So well done. And as always, if you've been given time away from your official duties to participate in these lectures, please do thank your supervisors for that. It's a unique opportunity that they're giving you. So as always, do send me an email with your 3 learning points, and then you can get ready for lecture number 8, which will be entitled Data Sources for NCD Surveillance, and that's going to be released next month. And as always, thank you for your hard work and all that you do to make the Pacific a better place.